to Radiology Rounds. I am your radiologist, Dr. Todd Berry, and this is our case of the week for July 24th, 2023. Our patient was a 55-year-old female who had a history of smoking and presented to the emergency department with chest pain. Her workup was essentially unremarkable without any significant abnormalities on her EKG, physical exam, or laboratory testing. A chest x-ray was obtained and presented here with the most recent exam on the left. This is in March 2023, and then a prior exam for comparison from about 1 year before in April of 2022. So if we start looking at the new current chest x-ray, one thing you always want to remember when looking at a chest x-ray is whether you have a approach to come from the inside out, the ABC method, or another method that you might follow. The most important thing to remember is that you have a systematic review. So I typically do the inside out approach, where I start in the midline structures, the mediastinum, and then work my way out to the lungs. Whichever approach you follow, eventually you're going to get to the lungs. And on this exam, you should notice that in the right mid-lung, there is a rounded opacity projecting over the right posterior rib there. And when you compare it to the old study, this is a new finding. So in the setting of chest pain and a new rounded opacity in the right lung, you really want to ask yourself, what are the possible considerations here for differential diagnosis? You would think about something like a pneumonia, and obviously neoplasm would be the top two things on the differential. And there are a number of different infectious organisms that could possibly present as a sort of a rounded pneumonia. So what is the next best test to order? So you're going to want to get a better look at this with cross-sectional imaging. So chest CT is going to be the best thing to do here. You could do it with contrast, which would be ideal to really highlight the mediastinal structures and assess to see if there's any abnormal lymph nodes at the same time. Or evaluating a pulmonary nodule on a chest CT does not require contrast. So if there's like an allergy to contrast, or maybe another contraindication like some poor renal function, then you would not necessarily need to use contrast to strictly evaluate this pulmonary nodule. I saw a few comments that people were talking about possible pneumothorax. Again, a pneumothorax, you're going to see a thin white line and absent pleural markings beyond that line to the periphery of the chest, so which is really not present here. Sometimes it can be a little bit difficult looking on your computer screen without the benefit of a PACS to kind of window and level. But there was no pneumothorax here. So really the only finding of interest here is the pulmonary nodule. So let's take a look. The chest CT was performed, and this indeed confirms the presence of this rounded subpleural pulmonary nodule. It's about 2.5 centimeters in diameter and centered in the right lower lobe. And one other thing to keep in mind too, you may look at this and see that it's in the mid-lung, and you might think that it's in the right middle lobe. Remember that to localize something in the right middle lobe on a chest x-ray, really it's ideal to have the frontal and the lateral view, which we don't have here. And also, if it was in the right middle lobe, it would typically obscure or silhouette that right heart border. So we know that this is not necessarily in the right middle lobe, and this turned out to be in the right lower lobe here. So again, this is a pretty well-defined nodule, maybe some faint ground glass along the periphery, and then the rest of the lungs were clear. There was no other nodules to be seen. So given this finding, new nodule, highly concerning for a neoplasm. Infection is not totally out of the question here, certainly isn't a possibility. Interestingly, if we go back, she had a CT done from, this was several years back. And if we look here, the patient actually has what looks like about a 5 millimeter nodule. And that was a new finding on this study from the study that was done before this, in which there was no study at all. That nodule was mentioned, and recommended to get a 6 to 12 month follow-up because it was a new finding, and given her history of smoking, that was never followed up on. So, one thing that you want to keep in mind too, when you're ordering these studies, it's always critically important to make sure you're following up, make sure that patients get the appropriate follow-up that they need, and that they're aware if there's an abnormality that requires follow-up. So, taking that finding into consideration with the new pulmonary nodule, we are certainly very concerned that there is a neoplasm here growing and progressing. The patient was referred to a pulmonologist, and they ended up ordering this PET CT. So here you can see a very hot pulmonary nodule with intense radiotracer uptake, and this turned out to be a adenocarcinoma. We can look at the CT-guided biopsy that was done from a posterior approach. You can see our needle going in directly into the posterior part of the nodule, and that was it. So, pretty significant finding. Was not necessarily causing her chest pain, but certainly a significant abnormality that needs to be assessed on the chest x-ray. So, don't be concerned if you didn't see that one. You want to obviously take time and get good at looking at these chest x-rays. If you have not already developed an approach to looking at chest x-rays, I can send you a link for my approach with a free tutorial on my approach to evaluating a chest x-ray. And if you have any questions or comments, please let me know. But thank you for participating.